think the exciting concept that knits together what Regina was talking about, what Maureen was talking about, is the idea that we are, for me anyway, as a clinician, it's remembering why we were clinicians in the first place. Getting to think about the goals of patients and how you can creatively and successfully help them meet those goals. And I think that the divide between the patient perspective and the provider perspective breaks down the minute you realize we are all patients. We are all human. We all have a mortal life cycle. And in every one of our families, the table gets turned on us, and we end up being on the other side. On these banners are projects that have affected lives of people around me. On my own team is a surgeon who, I didn't mention I'd tell about this, you may not be happy about it, but a surgeon who had a cardiac arrest doing our work. And because he was able to get to a cath lab with a door-to-balloon time of under 30 minutes, despite getting chest compressions for more than 20 minutes along the way, he came back, and he's here today. And he is the key reason, I'm not the key reason, that the Safe Surgery program is working in South Carolina. Bill Berry, cardiac surgeon who went through this himself, is a key reason why we are being successful here in partnering with you and making this work go. There's another person around me who is affected by some of the work you're doing. My son has a cardiac condition, has had to have central lines placed multiple times in his life, and has never had an infection. 7% of central lines, if you don't follow a basic set of rules, making sure you wash hands, making sure the whole body is draped with sterile drapes, making sure you put hat, glove, mask, sterile equipment on, 7% will have an infection, and that's a 25% mortality in the kinds of patients who have those infections. And because of work like you're doing, that changes life for people around us. Now, the person around me that I've been thinking about recently is my own mother, who 6 weeks ago had a total knee replacement. And I think and she had a fabulous experience. It was from start to finish, really managed by a team of people who really thought about how they wanted to be a team along the way. And it was really partly because of a team led by a surgeon who was intent on driving that process and re-engineering it from start to finish. But one thing that I noticed along the way was exactly what makes it so hard for us to have healthcare go well. From the moment she arrived with her terrible knee pain and needing to have sorted out what needed to be done, all the way through to the decision to have the total knee replacement, the arrival in a preoperative clinic to screen her for surgery, the surgery itself, the recovery, and the physical therapy, up to just the moment of discharge, we counted 19 different physicians that were involved in writing orders or providing some component of care. When you added in the total number of people involved, it was 63 people who had literally touched my mother, watching just people coming into the room during her 3-day stay, the people who would read her x-rays, the people who, while she was in the hospital, had her nutrition, then planning the discharge, being able to be involved. This is our great difficulty. The power we have inherited from the last century of medical discovery has been the ability to take a woman like my mother, 74 years old, and help her regain a life, because she'd become so hobbled by her knee she was effectively disabled and virtually housebound, no longer able to drive anymore, great difficulty walking. And what she has gained in the last 6 weeks is freedom and a chance at life that you couldn't otherwise have. This is more expensive than what we might have offered a generation ago. You'd get an aspirin and a small prayer, and then that would be about it. But now you can have a $50,000 knee replacement. And the cost burden of that is weighing us down until you realize that there is a bell curve. There is a wide gap in the range of those kinds of costs. Because it turns out there are places that it will cost $25,000 and other places it will cost $120,000. And there is no relationship between that cost and the actual result of the care. That is, the places getting the best results are not the most expensive places in the system. They are often among the least expensive places in the system. And they become among the least expensive by figuring out how you take those 63 people and have them pointed in the same direction, working together instead of against one another. How they incorporate evidence about what the best possible methods of care are. How they work together, surgeons all working together, and other clinicians, physical therapists, nurses, and so on, to solve the problems that the patients consider most important. And yes, also working together to sometimes negotiate in a very hardball way with the manufacturers and everybody else that make the equipment to be able to say, no, we don't need to pay what you're asking for. But that capacity has only existed in tiny little pockets. It is the effort of the surgeon we happen to pick over 10 years of his life to get those 63 people onto the same page, and it has been blood, sweat, and tears. And not all of his colleagues go along with it. And we are trying to figure out how you make sure that kind of care happens for an entire population of people, a zip code in Columbia, South Carolina, or the state, or in fact, our whole country. But it starts with what you are able to discover and solve in a zip code. Because the first place that starts to become successful teaches others. And as we think about our program in safe surgery, that is what the backdrop really is to me. The backdrop is learning how to become more like a system of care. I've called it going from cowboys to pit crews for patients. We've all been hired, trained, and rewarded for being cowboys, having our own independent point of view as the primary aim and value of being a clinician. But when you have 63 cowboys, you get nothing of the sort. I, in fact, got a chance to meet a cowboy a few months ago, and I said, how do you do your job? How do you get several hundred cattle across dozens of miles? And he explained, well, we have a system. Every cowboy has a position. There's a lead. There are other ones that are in particular places around the cows, steer. You had constant electronic communication. They had checklists for what inoculations they needed to give, how they're going to handle bad weather, what they're going to do if any of the cows fall sick. Even the cowboys are pit crews now. And that's what we're trying to learn to be. The program in tackling safe surgery is about taking our first steps towards really becoming like that. If you think about what is our most common source of major risk that people face in the course of their lives, that we subject them to in the healthcare system, that claims 1 in 70 of the people who go through that process, that is, they die 1 in 70 times. That is surgery. And furthermore, this is our largest source of costs in our hospitals. This is half of hospital spending. Now, boards would call it half of hospital revenue. And this has been where some of our great sources of difficulty are. And what we've attempted to tackle then is this incredibly ambitious project to try to make the safety of surgical care just simply a little bit better organized, because it can produce some remarkable results. So when we launched Safe Surgery South Carolina 18 months ago, in partnership between the South Carolina Hospital Association and our team at the Harvard School of Public Health, and in trying to achieve certain targets for how we can simply have care that's just a bit more organized, what our goal was to measurably reduce surgical deaths and complications for an entire population, for a state. To think of surgical care as a system of service for the population in the state, and ask that that system of service perform better with fewer complications and deaths. And there was a kind of dream goal, a stretch goal, that we might be able to get the surgical death rate for hospital surgery below 1%, when the starting point is about a 1.3 to 1.4% death rate for the patients in the state. And that translates into thousands of lives at risk, but also potentially saved. And the method that we decided to take to be able to try to tackle this, our strategy, was to see if a simple checklist that teams could use to ensure better communication in operating rooms could take the highest risk moments in that care, which is when you roll into that white-walled space, and ensure that a basic checklist is used by the team, effectively, meaningfully used by the team, for every South Carolina patient undergoing surgery by the end of 2013. The basis for this work came out of work that we had done with the World Health Organization, where we had been tasked with asking what can be done to try to reduce deaths in surgery on a global basis. And when you don't have a lot of resources, the question then came, well, what's our most powerful way that you could really change care? And what we identified was, just like you're identifying as we talked about the system this morning, is that that even within an operating room, people are all cowboys. They're all doing their own thing. And no one's necessarily making sure that you don't remember, that you don't forget the basic key things that have to happen that could save lives. And when we focused and really tried to address what the list of key accomplishments are, what we identified and tested now 3 years ago was a set of pauses. One of our colleagues, I believe it's at Palmetto, one of the Palmetto Hospital, but he'll have to correct me otherwise. I love that he causes it the pause for the cause. A pause before the patient is put to sleep to make sure a few checks are made. A pause before the incision is made to make sure the team's together on what the goals of the operation are. And then a pause before the patient leaves the room to make sure that the plan is all put together. And there's what I call some dumb checks and some interesting checks. The dumb checks are things like, do we have the right patient? Is it the right side of the body? Is blood available if this is a high-risk case? Have we made sure we know the allergies? Have we given an antibiotic in the 60-minute window before the incision is made, when it actually can cut the infection rate by half? All of those steps. But then there were the interesting checks, which were around the fact that you can't make a recipe for surgery, but you can make a recipe for how to make a team be the best prepared possible for handling whatever is going to come. And so that meant asking that the team at the start of the day introduce themselves by name and role, everybody in the room. If there's a medical student, if there's a patient care assistant, that they introduce themselves. And then that the team walk through with the surgeon briefing the team on the goals of the operation, anything unexpected the team should know about, the anesthesiologist reviewing the medical issues of the patient, the nurse discussing making sure that their plan for the equipment is the one that everybody else had in mind, and making sure that they don't have any questions that need to be answered. Just simply having a discussion, a short one. most patients' reactions when you go through this, their reaction is to say, "You mean you don't already do this?" And we found that we didn't. We tested this in 8 cities around the world and deliberately tested in some of the top centers, premier centers in the world, University of Washington in Seattle, Toronto General Hospital, St. Mary's Hospital in London, where the Queen is treated, in Auckland, New Zealand, but then in also rural Tanzania, in a crushed city hospital in Delhi, and in Manila in the Philippines, and so on. And what we found was that in every hospital, complications were reduced when they adopted the checklist. The average reduction in complications was 35%. The average reduction in deaths took them from 1.5% down to 0.8%, a 47% reduction in deaths. This has since been confirmed independently in other studies. A Dutch group took the checklist approach and brought it nationwide to a panel of hospitals in the Netherlands, and what they found was eerily, virtually identical results, taking their surgical death rate from 1.5% to 0.8% and reducing their complication rates by a third. And then published in the journal in JAMA, the VA system adopted the WHO Safe Surgery Checklist in a team training model where they took a day out of the operating room and trained people in how to, had them practice basically in beginning to use the checklist and have some communication practice about how to brief one another and talk through these kinds of cases. And they too ended up discovering that they had an 18% reduction in deaths compared to controls, that you could follow right along as it rolled out from hospital to hospital, just watching the death rates fall. Our question was, now having demonstrated that this could work, could you do it in such a way that you could change a patient population, that you could help an entire state? In a VA system, everybody is salaried employees of a government-run system, and you can have this kind of top-down, centralized, here's what we want to achieve kind of goal, and sometimes top-down works, in this case it did, but sometimes it doesn't, and there can be serious pushback. And one of the things that that is a real test of these kinds of programs is, after the top-down goes away, does the system sustain and stay? And we won't know in a VA system how well that really goes with time. But what we do know is that it is an incredible challenge, more than people really quite necessarily understand. In our work, we have done a number of projects now trying to roll the checklist out broadly, and we do find substantial resistance. The resistance is most commonly from physicians. And the reason why is partly that we aren't used to having someone else tell us how to do something as intimate as how you talk in an operating room or how you do your operations. But I think the deeper, more fundamental reason is that all of us are willing to change and give a try at something, and if it actually works out, we tend to stick with it. And I think when we surveyed teams 3 months afterwards, it was very striking how much they valued or thought that the checklist made a real improvement. You had 80% or more telling us that they had a very positive experience, actually observed the checklist to have saved a patient from an error, didn't think it took too long, those kinds of responses. And yet there continued to be significant resistance, and what we gradually traced it to was that at the center of using a checklist with your colleagues is a different set of values. You're moving from thinking that this is a show all about serving the surgeon who comes into the operating room to being one where your fundamental premise is, what do we all need to do today to make sure the patient gets the best result. And that involves invoking 3 values that we don't necessarily have, and just to use the checklist forces you to express those values. Number 1 is humility. The willingness to acknowledge that no matter how expert you are, no matter how well trained, no matter where your degree came from, you can and will fail. Second value is teamwork. The belief that one way to be saved from those failures for the sake of the patient is that others on the team can help if you engage them and make sure that we're all working together, that a group of people can be more successful than individuals. And the third value is discipline. The belief that doing certain things the same way every time is a protection as well. But those are hard to learn. They're hard to embrace. And what we're in the discovery process with you in trying to unfold is, how do you do that? How do you create that change to make it meaningful that we're trying something that brings a whole team together? We've worked with Hospital Association, another state that was able to drive the checklist into every hospital using financial incentives. They worked with Blue Cross Blue Shield in their state to offer a pay-for-performance contract for being able to do the checklist. And by the end of the year, every hospital had documented that they were doing the checklist faithfully. We just published the results from interviewing the doctors and nurses in those hospitals. We took 5 and found that 3 out of 5, they weren't doing the checklist. They just were getting very good at documenting a bunch of tick boxes. But was anybody asking before the operation started, what are the key medical issues of the patient? Do we have a plan? Does everybody know their role? Are we actually doing this together? That wasn't happening. And so the challenge for us in South Carolina has been how to begin to achieve that. One of the things that we ended up doing was to get a sense of just how hard it is. We made a video of one of the first places to actually roll out a checklist, actually put it in place and see what it felt like. And interestingly, in this video, the people looked an awful lot like actors we've seen before. Maybe we can show the video right here. I think that was MUSC. I'm not sure. We have embarked 18 months ago to be able to tell this story to everybody involved in surgery. Everybody involved in surgery. And the progress here has been extraordinary. I don't know if we can get the next slide up. We had a plan for how we were going to unfold creating a change in the way that people practice to incorporate just this one little 2-minute set of checks. And in order to be able to do that, we needed to work where there is no network. One of the great difficulties is, even though this is half of what hospitals do, there is no one place where people get together to ask, how should surgery go? Surgeons are widely divided by specialty, and so there are the orthopedic surgery groups, and there are the general surgery groups, and the vascular surgery groups, and the cardiac surgery groups, and they never get together, let alone get together to include the anesthesiologists and the nurses and everybody involved. And so what we needed to be able to do was really use the hospital leadership to build a network where there was none before. And so we walked through a process of first engagement to ask the hospitals whether they would participate, then to go through a set of waves of education with the teams that could come together in the hospital so that they could learn how to successfully introduce this into a wide range of practices and people, and then to begin using our methods to strengthen what we're doing and then measure whether the effect is getting anywhere near the outcome. So what I'm going to offer you is a little bit of an interim report on how that's gone. The work has been to start for a few months of relationship building and then working through our early adopters in a wave of implementation with the first group of hospitals that were the most ready to go. We are now through the second wave of working with the middle adopter group. We're going to be about to launch our effort to engage our late adopter group and try to really cement our planning, and then begin working to take the model we're building here and take it nationwide to other states as we go along. And then our goal is that by the end of next year, we will be able to describe to you exactly what has been accomplished. Just to get through the last year of work, I want you to understand what's been involved. It started with asking the CEOs to name a team for us of people that could help us in every hospital, and that team had to include a surgeon, an anesthesiologist, a nurse, and a member of the executive staff. And with that, we ended up having, in the course of 1 year, more than 1,300 people that have come together to work on this project. They have together spent 140,000 total hours across the state making this happen, putting the checklist into place. They have themselves spent 1,600 hours just learning and educating themselves in what we've used using telecommunication technology, a regular series of webinars and two-way communications to allow us to connect to places all across the state and be a collaborative that could meet weekly for an hour or a couple hours a week, and not have to travel to make it possible for people to know one another and make it happen. But then there had to be a certain amount of face-to-face time, and between Boston and here, and then people here from the South Carolina Hospital Association moving out through the state, there have been more than 24,000 miles traveled in making this work. We had ultimately the CEOs of every hospital in the state signed on to participate. We had people get together to be able to make it a checklist that could really work in South Carolina by making it your own. That included adding components we didn't have on the WHO checklist, which are components that included things that help meet Joint Commission certification. And so that was combined together. And then, interestingly, some things that really, I think, are now influencing how we change the checklist to work in other places. For example, people asking that the surgeon make a statement that, of asking in their own way, does anybody have any concerns? And if you see something that concerns you during the case, please speak up. This has been a critical component because operating rooms are extremely intimidating, and people who have a little doubt about whether something might or might not be wrong usually don't say anything for fear they're going to get their head bitten off. And of course, this is the surgeon's show. And you put that in here, and it's amazing to see it happen when people say it and mean it. And to find that this is spreading and working and going to place. I was very skeptical that this was something that people would even do, but we're seeing that they're doing it. The 60 hospitals out of the 65 that signed up have actually actively participated. You lose places with every level of demand you ask along the way. And so there were a few hospitals for whom that was tough. And as we've gone along, if we could play the next little animation, we've had a process of moving the hospitals through waves of participation. Actually, I can put it in numbers here. It's probably the easier way to do it. In our first wave, we had 23 fully participating hospitals, meaning that they joined in on the weekly calls that allowed us to essentially walk through a process of step-by-step, take a look at the checklist in week 1 and see, have people already started using it in your hospital? Do you have to make adjustments to make it work in Palmetto or in East Cooper or in other places around? And by the end of that period, you had these 23 hospitals. These were the ones that were already caring for 57% of the surgery patients in the state. In the end of Wave 2, which just ended this past month, you had 13 fully participating hospitals, and again, the 12-week seminar series, walking people through the kind of homework assignments of accomplishing, trying to move the checklist through. And that involved another 13% of patients that were touched by the process, bringing us to about 70% of the patients in the state are now enrolled in processes that are actually reaching them. There are many things that we've asked the teams to be able to do, but probably the most important component of it, where it's having its greatest impact, is in trying to figure out how you overcome the resistance of professionals to trying something like this because of the ways in which it is just a different way of practicing. And just throwing facts at people and saying, well, the surgery data shows that, you ought to do this, is not, you have to have the heart and the head. And the most important thing we're finding that they do is something that the pharmaceutical detail reps learned long ago, which is talk to people one-on-one. The pharmaceutical reps have a rule of, they say it, touch the doctor 7 times. And that's how you get them to change what they prescribe to the drug you want. And that's why they hang out by the stocking cabinet to put the samples in there, just to have a chance to catch the doctors they go by and say, how's your daughter Debbie doing in her soccer season this year? Just build the trust. And so what we asked the teams to do their best that they could do at doing, they already know their doctors, but just try to talk to them one-on-one to be able to ask the magic question, will you help us? Not this is what you ought to be doing, happy to explain why, happy to show how, but how do you think we're all doing at accomplishing these goals in our hospital? Almost always people will say, I wish people would do, they'd be better about this. I'm doing it, but, what about everybody else? And then asking, will you help us? But that's not easy. Some of you have been part of this, and when you've been punched a few times, when you've gone in and asked people to help you, and sometimes they're not always as friendly as you like them to be, it makes you reluctant to go back into the fight. But when we keep on putting that hand out there and just asking for a little bit of help, people are making genuine progress. We see it in just the experience of the practice. What we're hearing from people where the checklist is going in is not just that you're seeing a change in statistics, it's a change in the culture of care, where people feel they have a voice. We're moving on to wave 3, specifically trying to solve 3 kinds of problems in wave 3 that we found we were facing. Problem 1 is that there is no hospital that has achieved full implementation. That is to say, in their hospital, in every operation, that they can count on this just being the way it goes. There is tremendous success in many places getting almost there, but we are partially implemented in the hospitals that touch 70% of the patients in the state. And making it go to full implementation is one goal. The second goal is to reach the remaining 29 hospitals that have about 30% of the patients in the state. And those places have not really engaged enough that their teams are, that they've really named teams that have gotten the support from their executives that they're really going to do this. And so our work in this next 12-month period is to specifically be able to approach those hospitals to get them to at least partial implementation and moving this process along. And then the third group that we're trying to engage with is really involving patients in helping us drive this process. And we have patients who are now starting to work with us to figure out, can we use media in a helpful way, not in an antagonistic way? Can we make sure people know the stories of patients who are both being helped by the care and in their own hospitals, that there are people who have been hurt by the care for lack of these processes as well. And it's really engaging patients, because making that last lift is going to, I think, take the public's involvement as well. The effort, I think, gives us some sense of what we're going to be able to accomplish. This is a state where we do about 400,000 operations a year. And that, in many ways, is just a tip of the iceberg, because there is an additional 60-some thousand operations done in the ambulatory centers in the state. And then there are all the non-surgical but highly invasive, just as risky procedures, such as endoscopy, cardiac cath labs, and so on, where these basic principles of teams needing to be able to work together and make sure that everything before the procedure start is just as it should be, and that all the plans for the patient are put together, and again before the patient leaves that procedure, that starts to be simply the way we do things. The opportunity to expand the safety of what we do is tremendous, and already we're seeing several of the centers that are finding it, in fact, easier to implement this as a process that extends to all kinds of procedures rather than just selectively the surgical procedures. We're starting to see that this is happening. Now the question is, we mentioned that we had this core goal of seeing if we can drive the complications and deaths down in the state. Our background is that medicine in general does improve, and we have had improvement over the last many years through a variety of things that are happening. The increasing ability and specialization in surgery. We're seeing many safety projects that have already moved through institutions, including infection prevention problems and so on. And what we think is that with adopting this program, that we will be able to take this curve from here and bend it further down to the 1% point. There isn't a state that has gotten the inpatient hospital death rate below 1%. And so your chance to lead the way and show how it can be done and what it takes, and help us discover for our team what the recipe is that get us there. That's the tremendously exciting thing. What we see, interestingly, even though deaths are going down, complications have been rising. So what that tells you is that the main thing we're getting good at is how we keep a patient with a severe complication from dying. They get intensive care. They have very expensive care that can rescue them from that complication. But what we believe we can do is take this from a rising curve and turn it into a falling curve. And we're just at the first quarter of results where we're seeing what the infections are doing. And for the first time, instead of rising, we've had a quarter in the state where the infections fell. It's not achieved statistical significance. It could well be a blip in the data. And the very next quarter, we see a rise. We only know when you start putting one foot after the other and start to know whether a year from now we've seen each quarter go down, whether this achieves success. But after a long trend of rising rates of complications, it's the first glimmer of hope that this is actually changing care for an entire population. And what we found is that for every one of these complications you prevent, you save $14,000. This is the triple aim. Better health, better care, lower cost. It has to go deeper than just whether we move that needle on the complications, though. What we're trying to do is achieve something that patients and people who work in the system want to know. When Maureen talked about that painting of just being in a dark place where it's just not great to work in systems that don't work well. We're seeing some signs of that. We have 25% of our anesthesiologists and CRNAs feeling that they're not valued and respected as members of the team. Almost 30% of surgical nurses and surgical technologists. And also similar numbers reporting that they don't feel that we all work together as a team. My colleagues as surgeons, we often feel that the system works better than other folks do and that there is more teamwork. But even for us, 20% don't report feeling that the teams are really able to work together. We are seeing wide variability so far, which reflects our distance we have to go with the hospitals that are participating in whether, for example, there's a preoperative briefing that includes planning for potential problems, and still some wide variability in how meaningfully we've been able to get the checklist up and going, and yet some clear places where it's just becoming the real routine of care, and that's a striking thing. But here's the real, to me, the ultimate test of whether we're changing care. None of us should be working in hospitals where we would be afraid to be a patient. And we do have some hospitals where 100% of the people we are surveying tell us that they would feel perfectly, that this would be a place they'd want to be treated as a patient. But you start seeing places where 10%, 20% of their own staff would not want to be treated at the place that they work. And that is ultimately, I think, the real sense of the voting of whether we are succeeding or not. And we believe we can change this as well. We have received 114 direct observations where teams went into the operating rooms just to see what happens when the checklist was used. And they, just walking in and watching 114 cases, physically watched the checklist prevent an error in 7% of the cases where the checklist was used. That is the opportunity. I want you to have some understanding, a little deeper understanding of how this works by hearing what it's been like from the point of view of one of the doctors who've been involved. Chris Wright, where are you? Chris, right here's a cardiac surgeon from Greenville, Greenville Health System, has been part of the team assigned there to help bring the checklist in, and just asked him to come up and tell us a little bit about what it's been like when they've attempted to do it there.
Opportunity to let you know a little about the Greenville Hospital System's experience with the surgery safety checklist. About 18 months ago, we made a commitment as a system, the board, the medical staff, the nursing staff, the administration, to engage in this project to put a surgery checklist, a safety checklist in every operating room in South Carolina to improve the care, the quality of care we deliver to our patients. The first thing we did was form a team, an implementation team, a leadership team, surgeon, anesthesiologist, an obstetrician, senior leadership, nursing staff, administration, and with the help of Dr. Barry and his team at Harvard, we modified the World Health Organization safety checklist to fit our particular operating rooms, and then we slowly rolled it out to operating rooms across the system to where now we have it used in all of our operating rooms throughout the system. We continue to get feedback from our staff, from our physicians, our nurses, and we modify what we're doing by this feedback, and that process is ongoing at this time. In the future, I see us using this leadership team to help the people in the GI lab, the cath labs, the ICUs, the nursing units, to come up with their own safety checklist to improve the care they deliver to their patients. Just to give you an example of the buy-in that we have and the enthusiasm, several months ago, the anesthesia staff and the nursing staff in the intensive care unit, the cardiovascular intensive care unit, came to us and said, can you help us develop a checklist for the transition of the patients from the operating room to the intensive care unit after open heart surgery? So we did that. And what we're seeing is the patients are less hemodynamic variability. We think there's going to be an impact on medication errors and earlier time to extubation. What we know we see is the nurses in the ICU feel much more comfortable that they're delivering the best care they can to their patients with this checklist. We have numerous examples, as Dr. Gawande said, about errors that have been picked up in the operating room or prevented, availability of blood, availability of implants, use of antibiotics, that the checklist has had an impact on. But one thing I'd like to tell you about is a personal thing that happened to me in my operating room. I was doing a routine coronary bypass, and we completed our surgery briefing. That's what we call it in our hospital. We don't call it a checklist because we felt that surgeons, if it's a checklist, they think it's something they shouldn't be involved in. So we call it a surgery briefing and debriefing. We went through our surgery briefing, and I'm proceeding with the bypass. And right before we get ready to go on the heart-lung machine to implement bypass, this little voice from the back of the room shouts, "Stop." Of course, everybody did. And this nurse, who's relatively new to our team, young nurse, she was actually helping the circulator, looked at me and said, "Dr. Wright, I'm not sure if this is right, but I think there's air in that line." And sure enough, there was a bolus of air about that big in the line leading to the patient. And if that had been delivered, if we had instituted bypass, if the patient hadn't died, they would have had a profound neurologic deficit. The most important thing is she was able to do that. She wasn't sure, but she felt empowered to be able to say something, that there was an issue she felt was going to impact that patient's safety, and she felt empowered to do that. And I left the operating room that day feeling very good about the real power of this tool, that it's a communication tool, that we're starting to have an impact on the culture in our operating rooms and the way we communicate in our operating rooms. And that, I think, is the real power of this tool and what's going to lead to improving the safety and quality that we deliver to our patients. And I just wanted to share that with you. Thank you.
Wow. If we haven't done anything, then just save that one patient here. We've already succeeded. I think one measure of the state of a country is what its smartest, best people spend their time working on and thinking hard about. And we're in a moment where there's an awful lot of our best and smartest people who think about things that kind of trouble us. How to tear down whoever's on the other side in the government, or how to get another $1 billion out of this or that kind of financial, for lack of a better word, financial trickery. But what we see in medicine and had been seeing in medicine was our own version of that, where some of our best and smartest people were mostly focused on how do you get more money out of the system? How do you get the revenues up, the beds filled, those kinds of problems? What we've really seen in South Carolina is an extraordinary change that's reflected in what some of the best and smartest people are thinking about now. They're asking, how do we get the care to actually work? And if we're not paid to make that successful, how do we change the way we're paid so that when we think about how to be paid well, we're thinking about the right thing? That starts with Thornton Kirby and what he's done with this hospital association to keep it pointed hard in that direction. And it's all the way to doctors like Chris Wright, nurses, anesthesiologists, others who've been involved in this project. What they are thinking about is what it takes to take a system that has not made any sense and keep moving it bit by bit forward so it actually does make sense. Take some of the highest risk, most stressful things we do and makes it even better. We've been a highly accomplished system of care, but one that has not met the full spectrum of needs that patients come to us with and subjects them to risks and hazards that just aren't acceptable. We have a system that has not behaved like a system, and for most people just doesn't make sense. The most common cry is there anybody in charge? That comes from patients. And what we're seeing are some of our best and smartest people start thinking about how we can take responsibility, how we can help take charge of making sure it becomes what we want it to be. And I think that story helps us see what happens when it does. I am just immensely grateful for the chance to have been working with your teams in the last 18 months, putting together our teams that have really become one team between Boston and the South Carolina Hospital Association, and then now this larger network of 1,300 people across the state that are changing surgical care. And in a larger way, creating a system that begins changing everything that's on this wall, from birth to intensive care to safe surgery, all the way through to the end of people's lives. We're taking some of the most critical moments that we are all going to face, and we're going to make those, quite simply, just plain better service for people and safer and with optimal care. This is, that's our opportunity, and it's going to come home to all of us, because we will come back and be dependent on that system ourselves. We will all be asking ourselves, is this a place that I would want to be cared for? And the answer, more and more in this state, is yes. Thank you.